Thanks very much, Kathy. I suppose I'm very happy to be talking at this stage of, if you like, how everything has evolved, and that we're into a very busy period, but nonetheless busy for a different reason than a lot of the times when we've been talking over the last few months. I think we're at that stage now whereby we've kind of gone through the process of a very tough few months in the sector, where we've had to assimilate an awful lot of information very, very quickly, where there's been new information coming at us very quickly, and these webinars were, which Dan and Kathy and the All Ireland Institute have provided, has just been a really good resource to try and filter that information and direct it, and I suppose translate it into application, in the nursing homes and in the sites where it was essential. And I think now we're at the stage of having gone through that process and having seen what happened with COVID as how we reflect on what happened. And I know that there's an awful lot of panels, there's an awful lot of inquiries, including the ministerial inquiry as to, how things unfolded and what we need to learn, what we possibly could have done better. And there's, most people in the sector I think have a lot of questions still as to what happens should we have a second wave. On the slightly more pessimistic side, I think when you look at what's happening in other countries, the question is, do we ever get to the end of the first wave? Not to mention worrying about the second wave, because it is very difficult to eradicate this in any, and COVID in any country. So I think we now are in a stage whereby we can take a breath and closely look, and I think this is why this is a really timely opportunity to have a chat, see what kind of information we can gather. It was a very tough time to gather information. I'm sure Gary and Susan will attest to that from a HICWA point of view. It's very difficult to try and get clear information. There's a huge emotion tied up in the narrative as to what's happened. But I think it's really important now that cool heads come in and actually have a look at trying to apply facts and a structure around how we analyze some of the facts that we might be able to get, and that gives us a process then to try to see what we have to do, what we need to focus on to try and prevent similar outcomes. We're in a place, I suppose, where almost 60% of deaths related to COVID-19 in Ireland, as is in the case in many other countries, have been in people living in nursing homes. And when we look across it, I think one of the facts that's lost is that a third of residents die each year. So these are places of care where there is a high a mortality rate on an annual basis. But when we look at what happened over the last few months, we see that mortality rate has been more than doubled. So that's essentially how it breaks down. We've done a few pieces of project, and by that it's myself and colleagues. The first one was a survey that we did. We sent out an anonymized survey to 45 nursing homes in CHOs and the community healthcare organisations 7, 8 and 9. And we did that actually to directly get from the sites clear information, because HSE information, there's time lags in the information as it's coming through different systems. So actually, to get the fastest access to the most reliable data, we went actually to the lead medical officers and the directors of nursing in those nursing homes. 28 of the nursing homes provided us with very clear information, and what we were looking for is what was their occupancy. We had a study period from the 29th of February when we had the first confirmed case in Ireland, right the way through to the 22nd of May, and it was quite simple top level information. We wanted to know what was the occupancy rates on the 29th of February, how many beds had the facilities got, how many single rooms, so a few bits of information with regards to the environment. And we did ask about staffing levels, overall staffing levels in the nursing homes. About 14 or so nursing homes gave us that information, not all of them. And then we really just want to know how many residents got COVID, how many of them unfortunately died with it, and how many of them had symptoms with it. And similarly for staff, how many staff got COVID, and how many of them had symptoms. And what we found was, so 21 out of the 28 nursing homes that responded had outbreaks. We defined an outbreak slightly different to the public health definition, in that we defined an outbreak as one resident confirmed. So in other words, we didn't include nursing homes where 2 or 3 staff may have had COVID in isolation, just because we couldn't, on the basis of a survey, know whether that was acquired within the facility or that was acquired outside of the facility, because we didn't look for any details relative to the individuals. It was an anonymous survey. So to counteract that, we really only included facilities that had a confirmed resident, and that was our baseline. So 21 out of the 28 had a confirmed resident. In those, what we found was about 46% of residents, had a confirmed or suspected. So 43% or so had confirmed COVID. Another 3 or 4% had suspected COVID, but for one reason or another, either it was early on when we weren't necessarily testing everyone, or people who passed away before they could be tested, or people who couldn't tolerate testing. There was about another 3 or 4% who looked very likely clinically, the medical officer felt they had COVID, who were in it. So almost half residents in nursing homes with an outbreak got COVID. And the case fatality attributable to that was 28%. So when we put that in the overall context of, a case fatality for COVID of around 2% in the general population, going up to, maybe even we thought the highest rates of case fatality of around 20% in those high-risk multimorbid individuals over 80, we can see that 28% really demonstrates just how dangerous COVID was when it got into a facility. And I think this replicates why we're seeing such significant numbers in outbreak nursing homes. One of the things about this virus is it is a particular, it is particularly potent at clustering. And so that's what we really see in those nursing homes, where you had, there was very few nursing homes with small numbers. And when you look to see why is that the case, it becomes apparent then. So 25% of nursing home residents, on the point prevalence testing that we did in around the end of, I'm trying to remember when exactly, it was around the end of April, middle of April, 18th of April to around the start of May, there was the point prevalence testing. So 25% of nursing home residents were asymptomatic. So we identified another, so you have over a quarter who are dying with COVID, and you have a quarter of residents who are COVID positive and asymptomatic. And there was a paper out in Nature just yesterday which very strongly suggests that if you're asymptomatic, you're likely shedding virus longer than if you're symptomatic, and you're less likely to develop an antibody response that will give you immunity. The asymptomatic spread is a key part as to why this clustering nature of this virus goes on, and it's probably the main learning I think we have to take in how we respond to it in the future. With regards to staff, we found in outbreak nursing homes 25% of staff, where we had the total staffing levels, got COVID, and about 25% of them were asymptomatic. So quite similar to the residents, about a quarter of staff had no symptoms at all. And I suppose everybody here knows that the nature of the care that's delivered in the setting. So where you have asymptomatic staff and that high risk for continuing to shed the virus, it also was likely responsible for those significant numbers that we saw. The other piece then that we wanted to separate out, so we found that the median date for the outbreaks was in around the 27th or 28th of March. So in other words, half of the nursing homes that we looked at had an outbreak by that date, and the other half developed outbreaks afterwards. So we wanted to have a look and see whether early outbreaks versus late outbreaks made a difference. And then, the main difference that we saw was, so you still have quite a high degree of infection in late outbreaks versus early outbreaks. You still have over 40% in the later nursing homes developing, residents developing COVID. You have a slightly lower case fatality. So now I would have the proviso on that the late outbreaks were running into the end of the study period. So it may be that the case fatality or the true case fatality hadn't become evident at that stage. So I'd be slow to make too many deductions on that. But it was a slightly lower case fatality. But the real interesting finding was that far more patients had recovered in the late outbreaks than in the early outbreak nursing homes. So nursing homes that had outbreaks early on continued, and the outbreaks went on for far longer than outbreaks later on. And I suspect that's to do with the learnings we had from the use of PPE, access to testing, better knowledge about isolation, better knowledge about in particular the atypical symptoms and the asymptomatic spread of this. So you can see a clear learning within the sector between those early outbreaks and those later outbreaks, albeit with the caveat that where we were able to look at staffing levels, there were more staff significantly, that we had identified with infections. Now, it could have been that there was greater access to testing, but there was higher levels of staff identified as having COVID in late outbreak nursing homes versus early outbreak nursing homes. So there's an awful lot of way. I think it's really important, and this is interesting stuff, and it's subjected. We've submitted it for peer review, so we're just waiting. But it is available for people to read. We have it up on a service called medRxiv, whereby this information is freely available. And if anybody who wants to see this paper as it is in its pre-peer review stage, I'm happy and free to share it. But I think it's interesting because it actually starts to put some actual figures on that narrative that has unfolded, and as we can have a look at it. And we felt certainly, and this was with colleagues from other geriatricians, from colleagues from Kennelly Hospital and Beaumont, amongst others, who put together this information. But we felt it was actually quite accurately reflective of what we were seeing, and I'd be interested to hear back from people in the institutions, in nursing homes themselves, as to whether or not they felt it was. The other piece of research that we did was with my colleague Romero Ortuna in St. James's, where we took that now infamous list of the league table of nursing homes that was in the Irish Times, which I know many found a bolt from the blue and upsetting. And we took some information on the nursing homes that we were able to glean actually from the published HICWA reports. So we were able to actually readjust that league table and adjust it for the bed base, because they had presented, of course, the league table in crude numbers of mortality. So we adjusted it for the bed occupancy rates in those nursing homes, which of course dramatically changed the nature of that league table. It was nonetheless, it's no less of a tragedy that you have 30 people die in a 150-bed nursing home than in a 45-bed nursing home. But of course, it makes a big difference from the way we interpret the facility. And I suppose that was we felt very strongly that it was slightly unfair how that information was portrayed. And then, as much as we could do, and it'll be, Susan and Gary will be able to talk to this a bit better than us, we try to have a look at, the preceding few years of the HICWA reports and try to see, was there an association when we looked at, occupancy-related mortality and previous reports, from HICWA, was there a relationship? So was there something that we could see? And we looked at all of the usual, the criteria that HICWA would apply. And really, we found no association between any of the criteria that we would look at generally from a perspective, from an infection prevention control environment and things like that. There was nothing that identified that one nursing home may have been more likely to develop an outbreak than the other nursing homes, and that was on the basis of the 100 or so nursing homes that we had those numbers for. The caveat, and yet again, that paper is free to review. It's up on a website called LTC COVID, which has assimilated an awful lot of the international literature on COVID outbreaks in nursing homes. The caveat to that is I think within a few days it was evident that the data in the Irish Times wasn't up to date and wasn't necessarily accurately reflective of the mortality in nursing homes. And it was a far less, I suppose, you're looking at it, it's a retrospective glance rather than a prospective glance. So you're looking back, knowing what you know now, but you didn't design it in a fashion that you would be, that you would if you were looking forward and trying to make assumptions between it. But I think what we felt from that one, from that particular report was that you get away from this narrative of good versus bad nursing homes, and that you kind of, you have a look and see what it was across the sector that influenced these outbreaks, and that you try and have a constructive engagement rather than assuming that a nursing home that had a significant outbreak, that had significant mortality, had done something wrong. And instead you acknowledge that where COVID got into a nursing home, unfortunately, it had a significant impact almost universally. There was very few nursing homes who didn't have a significant impact if COVID got in. And in reality, I think community spread around nursing homes, if we ever got to, and it is a piece that is possible to look at now that we have a little bit of time, if we looked at the density and significance of community spread around long-term care facilities, I think we'll see that that was probably a very significant factor. That nursing homes that were in urban areas in particular, where there was high levels of community spread, it meant that it was very difficult for staff with all the best precautions in the world to, in those early days when we didn't know so much about asymptomatic spread, when we didn't know so much about atypical symptoms, it was very difficult to have any other scenario unfold other than the one that did. That said, I suppose now is the time to have the conversation as to how do you adapt to that, because there's no question what's coming through very clearly, and what we know very clearly is that COVID in nursing homes, as they are now in their conventional form, will have a very significant impact. And I suppose this is the real challenge that we have, is we can do a lot of reviews, and there's a lot of things. I think there's stuff to be encouraged, there's stuff that I think I would take as, and I'll stop very quickly now, but there's stuff that I would take heart in. I think, one, we've developed a huge level of experience. So we've now, nursing homes that had outbreaks, their staff have actually come through this. There's a greater awareness of how we use PPE. There's a greater awareness of how we manage interactions with people who may have infections. There's a greater awareness how we manage transfers in and out. And there's a greater awareness of how we might manage visitors from the community in and out of nursing homes. I think our access to testing, while not perfect yet, is infinitely better than where it was, and our ability to turn around testing and isolate people preemptively is much better than it was. And I think our general knowledge of the virus is much better. So our knowledge of those atypical symptoms that many people in nursing homes, gastrointestinal symptoms were more prominent than respiratory symptoms, that many hadn't got the temperatures, so that if you were just looking by temperatures, you would miss many of them. I think our knowledge on that has moved on an awful lot. So I'd be relatively, perhaps foolishly, optimistic that we are in a better place just by having gone through what we've gone through. But the real crunch is and we're doing an awful lot of outbreak closure meetings, we still have new cases that are occurring in nursing homes. I think that's important to state. These few cases that we see reported on the news, those are oftentimes related to staff or residents in nursing homes. So we still have new cases. We don't necessarily have new clusters, which is really good, but there are cases arising still in nursing homes. It will remain a very, very risky environment. And I suppose the challenge for us on these webinars, and as we kind of come out of this, I suppose, first phase, hopefully last phase, but at least the first phase is how we can work together to try and make sure that we're as prepared as possible.
Thanks, Sean. That's a very comprehensive overview, and it's wonderful to have this data in the early stage. And I think that this data also, in many ways, adds a voice in a formal fashion to what were largely initially isolated institutions doing their best to manage a very, very difficult and challenging pandemic. And it's important. And also separately, we've looked at the questions submitted through these webinars, and what we've identified is that voice as well, and we aim to publish that to give a voice to the group of people who are dialing in here, somewhat feeling isolated traditionally pre-pandemic from academic sites and from information, having to equip and deal with rapidly changing guidelines and rapidly changing access to hospitals and whatnot.